Well, good afternoon, everybody, and welcome to this meeting of the Mid and South Essex Integrated Care Board. You're all very welcome. Welcome to the members of the public who've joined us here, and also to those who are watching the live stream. A respectful reminder to everybody that this is a meeting which is held in public. It's not a public meeting. We've had apologies for absence. I'm not proposing to go through that list. I'd like to welcome Sam Goldberg to her first meeting here at the board. Sam, you're truly welcome, and we look forward to you contributing over the coming months, and maybe hearing from you later. And also, I'm very pleased to confirm Robert Percy's nomination as a partner board member coming from Thurrock and Council. It's good to have you with us, Rob, already helping us enormously. Thank you. We've got register of interest, and there's no update that I'm aware of on that. We've got some questions from the public, and I have a list here. I think it's Chris Paulite. Chris Paulite has asked a question which doesn't really relate to the agenda that we have today. It's about the hiring of psychologists, counsellors, and other mental health professionals. So we shan't respond now in this meeting, but they will receive a response just as soon as we put a response together. Peter Blackman has asked us a question about the Community Consultation Working Group in connection with our latest CEO report. What plans are there to provide regular communication about the progress being made by that working group to patients and public, including those in South Woodham Ferrers and on the Dengie Peninsula, and how, with the needs of those communities and Malden included in future plans for community care? And I think, Tom, you're going to respond to that.
Yeah, thank you, Mike, and thanks for your question, Peter. Me and Peter met with some colleagues and representatives from South Woodham Ferrers and Dengie last week, actually. And so we had a good conversation in terms of an update around the interim report that we're talking about elsewhere on the agenda today. And alongside that, we have shared updates for staff, stakeholders, and other partners. We've also shared that update through our virtual views platform for those who expressed an interest in receiving updates around the community consultation. Given the feedback that we got last week, I'm having a conversation with the team and those involved in the working group about how we can increase the frequency of updates around the work of the working group, and so we'll just need to conclude that in terms of making sure that the right information is getting out in a timely way, and clearly as part of the final report and recommendations and the decision-making business case, which will come back to this board, we will be considering not just the needs of the communities of Malden, but actually all of those which are affected by the proposals set out within the consultation document, which obviously includes communities across Mid and South Essex. And so we will expect to see a reflection of that need and the proposed changes and recommendations in the final set of reports and decisions that this board will make.
Thank you. We also had a question from Saeed Abrar Limbrick, forgive me. The question is, with the rollout of an AI-powered digital front door for self-referrals to talking therapies to areas except Mid-Essex, how can the ICB help support to ensure equity of access for all citizens? And Giles, I think you're responding to that one.
Yes, thank you, Chair, and thank you, Said, for your question. To provide Said with assurance Our ICS is embedding mental health as an intrinsic element of the strategic work plan in line with its ambitions set out within the joint forward plan, which was shared in 2023. This does include engaging with talking therapies providers as part of a procurement process approved by the ICB board in March 2024 to harmonise current service delivery across Mid and South Essex, which will ensure an equitable access offer for psychological therapies to all of our residents.
Thank you, Giles. And I now realise I've already failed today as chair because, Sam, you won't necessarily know everybody around the table. So we'll just do a quick round of introductions, if we may. And Peter, this will give you a natural opportunity to introduce yourself to those who don't know you as well, and colleague with you. So I'm Mike Thorne, chair of the board. Tom?
Tom Abel, chief exec of the ICB.
Matt Sweetin, medical director of the ICB.
Giles Thorpe, chief nurse of the ICB.
George Wood, non-executive member.
Neha Sabran, non-executive member.
Mark Balaam, associate non-executive member.
Jeffrey Olsen, associate non-executive member.
Mark Harvey, executive director for Adults and Communities at Southend.
Rob Percy, executive director, Adults and Health at Thurrock Borough Council.
Sam Goldberg, performance and planning director for the ICB.
Claire Hankey, Director of Communications and Partnerships.
I'm Pete Scolding, Clinical Director of Stewardship for the ICB.
Lucy Whiteman, Chief Executive of Provide Health.
Dan Doty, I'm the Alliance Director for Mid Essex.
Pam Green, Alliance Director, Basildon Brentwood, and Exec Director for Primary Care.
Alex McCann, Alliance Director for Thurrock, Exec Director for Mental Health.
And Cathy Bonney, interim CPO for the ICB.
Good afternoon. I'm Dr. Anna Davey. I'm the Primary Care Board member, partner member.
Good afternoon. I'm Barry Frostic. I'm the Chief Digital and Information Officer.
Hi there, Matthew Hopkins, Chief Executive of Mid and South Essex Foundation Trust and acute provider member of the ICB.
Hi, Paul Scott, Mental Health member of the board and Chief Executive of VPUT.
Afternoon, Jo Cripps, Director of System Recovery.
Hi, Jen Kearton, CFO for the ICB, Chief Finance Officer.
Thank you very much, and apologies, Lucy. It's so dark in here, I can barely see my papers, nor you. So you're welcome. Lovely to have you with us. We've got the minutes of the last meeting. There's a correction talking about the lack of light because we incorrectly stated that Mark Balaam was in attendance and yet didn't record Jo Cripps as being in attendance. I can only assume that it was so dark we confused the one for the other. So apologise for that. You have the minutes. Are there any other corrections anyone wishes to make? If not, we shall assume that they are a correct record. Thank you. And are there any matters arising that anyone wishes to raise which are not on the agenda? Thank you. There's two items on the action log, item 55 is complete as per the action log, and 54 is still in progress to be completed for our May meeting. So we move on now to the substantive agenda, and the first item is specialised commissioning, further delegation of services. And Matt, we're over to you, I think.
Thanks, Mike. Paper taken as read. As you can see in the paper, specialised commissioning services are those services that are often complex, rare, or require specialist intervention, usually from specialist centres, but not always. You can see from the Health and Care Act in 2022, the move was to move specialised services or specialised commissioning down to integrated care boards from NHS England. Now, the NHS England will retain some specialist services, but a majority would move to ICBs. We were one of the 3 ICBs where specialist services were delegated to us in April 24, which we as a board signed up to at the time. And the paper here today seeks for the further 11 services, so taking delegation to 70 services, to be delegated to ICB level. Finally, on the back of that, As you can see, the 6 ICBs in our region have formed a collaborative, technically collaborative is not the right word, but we have a joint commissioning committee, and I sit on that as the SRO for our ICB. And in that, decisions are made around specialised services across our region. So the paper seeks for you to agree and to, in fact, delegate authority to Tom, our Chief Executive, to sign the final release of the 11 services to be commissioned from NHS, from the ICB from April this year. Our host BLMK, so Bedfordshire and Luton ICB, host the specialised commissioning function. And as you can see, their staff from NHS England are moving over to them formally in July this year as well. So papers there, taken as read, happy to answer any questions. And thank you to Nick for doing the paper.
So, Matt, given that you're a medic, could you give us a sort of a characterisation of what these services sort of are for those who haven't got the appendix?
Thanks, Mike. So it really ranges, and it does tax your brain because there are some specialist services. So it ranges from specialised stroke services, for example, thrombectomy, where you actually will go in mechanically and remove clots from the brain. Specialists need specialist intervention and can't be done from a generalist point of view. Rare forms of cancer, sarcoma, for example, and treatment there, genetic conditions, and, for example, neonatal services as well. So a whole range of things. But the key bit is that often these services are lost when you don't pull them together. And so there was an idea to pool finance and the outputs for these rare but important conditions. And so that's the kind of things we deal with. And the other big thing is kind of cancer centres, particularly as well, chemotherapy. So that they are often included here, and there's a lot of work in that space at the moment.
Thank you. Any questions or comments? Neha?
Yeah, just a lot of these are complex, as you've just explained, Matt, as well, and the time frame in which all of these have now come across to us. In terms of our capacity to ensure equitable access throughout, what are we already putting in place? What have we learned from the ones we did, and how are we going to manage that?
The good news about this is that the host arrangements sit with our BLMK colleagues at the ICB, and we all have a seat round the table. So essentially what's happened with the delegated agreements is there is close working between functions within our ICB and back to central command to BLMK. There is a dedicated team with a managing director, and of course there are close cross-party working around service implementation and changes. If I'm honest, the last year has been about delegation, understanding the roles and responsibilities, and this year is around strategic planning and then operational delivery, i.e. what can we do for our residents in Mid and South Essex to either improve these services or bring them back locally where possible and explore that, or improve the pathways where we may not do the whole service, but actually we can do a lot of the investigations, for example, locally before we send off to specialist centres.
Thank you. Dan?
Thanks, Matt. Might be more a question for Giles on your left, actually. But when it comes to the oversight of quality and safety in specialist services that are provided by our providers, is that something that we pick up locally, or is that something that's done on our behalf?
I can take that, and Giles would certainly the expert in quality here as well. So we receive a formal performance and quality review through the Joint Commissioning Committee. So we as executive have oversight of that. There is a quality subgroup, but of course the papers are then distributed to ICB colleagues. Giles, I don't know if you want to come in here from, for example, from a mental health point of view or other elements of quality. We certainly share that, don't we?
Yeah, absolutely. So whilst there is a formal oversight under specialised commissioning rules, of course, for local services, which we do still hold a statutory responsibility for, to ensure safe provision of service, there is an ICB level responsibility which we continue to hold, and as well as that, quality representatives will liaise with the other ICBs and with BLMK colleagues to ensure that if there is any local concern or risk profile that evidence further scrutiny, then that will then come back into the local system.
Thanks. And Matthew, as our acute provider, I mean, are you comfortable with these new arrangements?
Yeah, very much so, Chair.
Thank you. I mean, I have to say, I was sceptical at first, just as to where this might lead us, but actually, having been given powers over dentistry, for example, we're a long way from being exactly where we'd like to be, let's be clear still, but we have been able to innovate hugely in that space. And the last numbers I saw, it might even be in these later papers, 70,000 people have benefited from, increased appointments, given that local flexibility. So let's hope, even though it seems slightly odd that it's in one of our neighbouring systems where it's hosted, let's hope we've got the power to innovate that comes with this, and therefore we can give benefits to our residents on our patch. So are we happy then to approve this? It has been through scrutiny in other parts of our committee structure. Okay, thank you very much. So we do. And we now come on to the stewardship programme, which is one of our great successes. So Matt, it says you're in the frame initially anyway.
Very short, Mike, for me. Just a big welcome to Dr. Pete Scolding, who's our Clinical Director for Stewardship, and to Jane Mason, sitting there in the gallery, as well as our Deputy Director for Stewardship. Just to say, this is, as Mike, you said, one of our big programmes, a real source of success. And I'm really excited to see how this moves to the next phase, as described in this paper. And one plug for our shining star, Pete, in the corner there. If you want to hear more about stewardship in the car, then Lead an Improvement in Health and Care, the podcast between Confed and Health Foundation. You get 25 minutes of Pete's voice telling you all about it as well. So I would recommend that. It's a great listen, and it shows the journey that we've been on as a system. So Dr. Scolding, over to you.
Thanks, Matt. I try not to give you 25 minutes of my voice now, but I did just want to pull out two things from the paper, if that's okay, and actually two kind of feelings just to help the narrative. And the first one would be pride, actually. I think this board can start to feel that sense of pride in the work that our staff has done within the programme over the last 4 years. And you backed it 4 years ago. You said, go away, work out how to make it work out how to make it deliver for people here. And we did, and our staff in 10 groups now have done that and done a lot of work over those 4 years. And you continue to back it each year that we brought back the updates. And there's 4 particular examples included in the paper that you've got today, but obviously many more different case studies that sit behind that, and happy to share some of those. And I think particularly in the last year, we've started to see some of those successes and achievements being celebrated nationally in the way that those things happen through the podcasts and the prizes and the conferences and so on. And that's great. But I think we've got 2 really solid things after those 4 years, 2 really solid things locally that we can be proud of. And the first one of those would be our group model. Our 10 stewardship groups we've got at the moment, 10 different care areas, from babies, children and young people through to ageing well and frailty, musculoskeletal health to mental health and everything in between within those 10 groups. And they bring together frontline staff, clinical and operational, to lead change and improvement within the system. And we've got examples within those 10 groups of teams that have now been together through right from the start for 4 years now, and have still got that really strong driving sense of mission and purpose. And that's quite an unusual thing to see, 4 years in, still going strong. So that's something which, I think we've seen works and is still delivering. So that would be the first thing. And then the second thing would be the track record that those groups have set over those 4 years of delivering big changes and small changes, supporting system priorities, improving services, improving pathways. There's a great range of things in there. As I say, 4 things in the paper, but many more that sit behind that. So 2 things really solid locally that we can take some pride in, that our staff have delivered over the last 4 years. But I think you won't find from anyone involved in the programme any sense of, mission accomplished, aren't we great? It's clearly a huge amount to do and those teams want to achieve within the system. So that takes me to the second thing, which is that feeling of excitement about the next phase. And what we would like to do, and is proposed in the paper, is to move from the kind of hothouse phase. Over the last 4 years, we've really focused on that group model of developing it and honing it and getting it to work effectively in our system, and to shift gear now into a whole system stewardship approach, where particularly we look to see how we can get the principles and the practices and some of the people from those first 4 years and bring those to bear on some of our shared big system priorities, particularly those that are now being shaped in the medium-term plan process. And so there's a couple of particular things proposed in the paper. So we provide that support to whoever those teams are that the system says you lead on those medium-term plan priorities, support them to come together to define that sense of mission and purpose, so that 4 years from now they can stand and they've made a difference that they can be proud of. And then the second thing, I think, more broadly, is to look at the ways that we can open out the approach, so that anybody, any staff member within Mid and South Essex feels like it's more accessible, more applicable, and they know, what can they take to help them make more of an impact through the work that they do. And then final thing would be, of course, to carry on with the work that the groups are doing, those 10 groups, to support them in their work to lead change and improvement. So thank you for your support in the last 4 years, and for supporting your staff to take part in that programme. And I hope the support will carry on for this next phase. Thanks.
Thanks, Peter. Thanks for your role in it. I mean, listening to you, we see how you persuade people to become involved, and once you have them in your clutches, they're not released. So it's good to listen to you. And for me, the delight of the model is it's people on the ground. It's doctors, it's nurses, it's administrators, it's all of those from our hospital, it's all of those from our community and mental health providers, it's people from the ICB itself working boundaryless on ideas that they come up with that have led to the material benefits exemplified in here, where you think, if we could move to the rest of cancer, what the stewardship has done in dermatology alone, just do the maths and see where that would lead us. It would take us to the forefront from where we are now, which is categorically not at the forefront generally. So it is a very compelling model. And for me, what I liked about the paper was the honesty was, if you innovate, it won't always work. Shock. Horror, because it depends on people, individuals, working relationships, doesn't it? And clearly, when that chemistry comes together, you have a major success. Tom, were you looking to burst forth? No, I was just checking.
I can say something if you like.
You, by all means.
So I think we've had quite a lengthy conversation within the executive team and the ICB around this, and so I think, particularly as we hone down on our priorities and our shared kind of system objectives over the course of the next kind of coming weeks, really, through the medium-term plan work, as Pete described, actually embedding this as a model of practice, I think, is really important, because we know that it is our colleagues, on the front line who see the opportunities, who can see who are, open to the innovation and the different ways of working, and are really important in leading the change. And so think about how do we embed the practice into the way that we work moving forwards, I think's really exciting and a real opportunity for us. Doesn't mean it's going to be easy, but it is. I think we've seen some really fantastic examples through the programme so far, and it's really how do we move it from being something that's special, to something that this is the way that we do things around here. And I think that's kind of this next stage of development that we're now embarking on.
Thank you. I've no idea who was first, but we'll start with Jeffrey.
Thank you, Pete, and thank you, Matt, as well. I think it's really exciting, really good development. I just want to check. Definitely, it's doing something really good on conditions, different conditions, isn't it? I want to check to what extent it's also dealing with issues around disparities and inequalities, and to what extent that's embedded as a principle or as a way of working in there. And perhaps I know that it does work with different population groups, but within that, to what extent, or either now or in the future, could it have more focus on around inequalities in particular situations? Thank you.
Yeah, Pete or Matt, either.
Yeah, shall I come back on that one? Thank you. And it's a really important point. I think probably the starting point for all the groups, whenever they look at, what's important in the system is the starting things to look at variation and to understand, where are the inequalities in particular outcomes or, access or resource use, and then they develop the kind of program of work to tackle those. So I completely agree. And it's very often, understanding that variation and inequality is right where they start with the improvement work. So yeah, thank you.
Thanks. Mark, I think you were next. Rob, sorry, I've lost my place completely because there was just suddenly a show of hands.
No, thanks, Mike. So I was in a session at the council this morning where I was told there was no stupid questions, and I'm going to test that theory here. So I'm fairly new to this. Found the paper really interesting. I really liked what the outputs are in the case studies. Yeah. So I suppose there's kind of a challenging question which I'm not going to ask, which is what would happen without the stewardship? Because to me, that's kind of thing which we should have been able to do, that should have been being delivered in a way. But on the basis it's been done through the stewardship program, let's not question that, but it just sits in there with me a little bit. I think accepting how positive the outcome, the output seem to be from the program, is probably linked to the last question about inequalities. But it's about how broad could this go as far as engaging possibly outside of the clinical world and engaging with other, with social care, with other, with the voluntary sector. I'm thinking through the lens of the NHS consultation at the moment, Fit for the Future, around prevention, upstreaming, the upstream work, the acute to community, primary shift, digital. Is this the kind of the program, the mechanism that may be being considered to broaden out to try and look at how we can work better collectively together in the future in that space?
And welcome to the board, truly welcome in your new role. Pete.
Yeah, thanks. And I think, that's kind of the definition of thinking big, isn't it, in terms of where it could go next. And I suppose the whole stewardship approach is based actually on an economic theory that won the Nobel Prize, Eleanor Ostrom's work on stewardship. And that's nothing to do with healthcare. It's to do with resource use by local communities. So the basic approach of those people coming together, people who know the resource coming together to make the best use of it, it has been applied to all sorts of settings. We've taken it and adapted it to our setting over the last 4 years, but absolutely, the basic kind of principles of it should be applicable to anything where you've got resources and people who need those resources.
And if I was just to come in there as well, it is a new way of thinking of things. I mean, it's been done elsewhere, but essentially I was just at a cardiovascular event yesterday where I was like, if you find me £200,000, we can do this great model. That's all well and good, but we never think about the totality of our resource and the value from it. So actually we never stand back sometimes and look at what we spend in one whole care area across our system, and then think about what are the outputs to show the best value for this, not just financial, but actually value for our residents as well. And so the challenge always back is, have you looked at the totality of the resource? Show me from a population health point of view where your inequalities are and where your variance is, and actually then target your precious resource to those interventions. So it means hard choices, but also probably better value. The trouble with our health system is we often go on innovation, but we lack to think about our totality of resource as well.
There is, I was thinking, Matthew, about the QI program in our hospital. We have, over the years, Rob, run this scheme where we get, this was in order to promote boundaryless working between the NHS and the councils that we're here to work with on many agendas, not just social care, and bring people together in teams to bring about innovation. And there have been some great successes there, and it's been a nice thing that I've been involved in, typically to go to the sort of final presentations of the teams from all of those different bodies who come together to make an innovation. And I've seen council members, I don't mean the elected officials, but members of staff from councils involved, for example, Matthew, in the redesign of the A&E second floor in Broomfield Hospital, and very proud of what they've been able to do from bringing their perspective to things. So we have got some experience of doing that, not within the IC, but within in the hospital program. So I mean, that's evidence that we're definitely up for this kind of activity. And I guess if there's particular things that crossed your mind, Pete would be very pleased to hear of them, or things that you know have happened elsewhere that we could, we're up for copying if it's good too. Anna?
Thanks, Chair. So, Pete, as we move towards a whole system approach, my plea is to ensure that you've got the broader primary care fully involved in all of your stewardship programmes, and that as we embrace the left shift agenda, which is fundamentally what you're trying to achieve, that you engage with both general practice, but also dentistry, optometry and community pharmacy, the broader primary care, at every step of the way, because that's where the success is going to come. So we need more of that engagement with the stewardship programme and broader primary care in the system, please.
And the opportunities, just going back to the previous agenda item, of where the unbundling of specialised commissioning, particularly, for example, dentistry, what could be done there in relationships between the colleagues that they would normally liaise within our hospital and so on. There may be, further mileage of mutual benefit there too, and benefit to our patients. Matthew?
Yeah, thanks, Chair. And I think when you came to our executive team discussion recently, I think you would certainly have come away with a sense of how much further could we go, because I think from the acute provider's perspective, as we work as a whole system towards those clear plans that will take us to a clinically and financially sustainable future, the delivery model has got to be based on this type of approach. So I think we're clear within the acute sector that a system-wide approach to a number of the challenges that drive cost and poor quality is the only way forward. The challenge that my organisation will have is bringing the right people to the table when they're already busy working in the ways that they're working now. But I know that we've already had some fruitful conversations, and we'll keep very much closely involved, Chair.
Thanks. I mean, I do remember we were in the distinguished location of the ballroom in the Holiday Inn in Basildon, weren't we, when much of this kicked off, and surrounded by exactly what you described, Matthew, very, very busy people, but they saw this as a route to solving some of the things that were getting in their way, if you like. And I guess that's what you rely on for this, isn't it? That you'll go even the extra mile beyond the extra mile you're going to free up things to enable things to move on. Jane, you've sat there. Is there anything you would like to contribute? There's a microphone on the corner there. You'd be most welcome to.
Thank you. Thanks for having me and inviting me to speak. I think probably the main kind of programme of work has been outlined, just to really re-emphasise the importance of the relationship building that comes with the stewardship, and the time that we take to, have those informal conversations to get to know people. It just smooths everything over when we then get to the real tricky conversations and some of the more challenging issues that we have to approach through this. So yeah, just not to forget the relationship building. But yeah, thank you.
Thanks, and thanks for everything you do as part of the team. So if there are no further questions or comments, I haven't missed anybody out, we're asked to do three things: endorse the overall progression of our MSc stewardship approach, from hothouse to whole system stewardship, and I'm hearing that we do. Support the development of key mission or priority boards as detailed in this paper. We do, and by the sounds of it, we'd like to add some more to the list, but then they won't necessarily be priority anymore, will they? And then thirdly, support the development approach for these boards and for the wider ICS health and care staff in principles of stewardship. So I think we endorse all of those. And again, Pete, Jane, and all involved, Matt, thank you very much indeed for everything you're doing there, because it is making a difference. So we now move on to the next item, which is contract awards for NHS general and acute services and ISP, that's independent sector provider acute contracts. And Jen, that's you.
Thank you, Chair. So the paper is here today seeking board approval for the actions we wish to take across contracts that are in excess of £10 million in their aggregate. So we have our main contract with our acute provider covering the MSEFT area. I have literally just been notified during the board that we will be changing the value on that to accommodate the specialist delegation that you've heard about earlier. We want to ensure that we have one contract in this space rather than two separate contracts, so that will come back round the governance, Chair. But what I want to just draw your attention to is the fact that we will be using the provider selection regime, direct award processes, A and B that we have, and that we are in that vein suggesting that we have MSEFT to continue to provide the services that they are currently providing for us. We will vary that for specialists, and that those independent sector providers that are currently supporting us with services such as ophthalmology, trauma and orthopedics, some urology and gynecological services as well, through the mechanism of patient choice, we will use the DAP-B process to award to those providers. I'd like the board to note that these are indicative contract values. We are still waiting for the NHS England planning guidance for next year, and we will continue to apply the principles in the planning guidance, and they will all be subject to continued negotiation as we go into 25-26.
Planning guidance being code for including how much money we're going to get and therefore what we can afford.
Yes.
Okay, and this is not an interview question, but for members, the under regime A and regime B, in a nutshell, can you summarise those two?
So regime A, or DAP-A, direct award process A, is where actually it's the most suitable provider. We would consider that there is not another provider that would be able to come in and provide the services that we get at this acute scale in the same way that Mid and South Essex Foundation Trust do across our hospital sites and broader. DAP-B supports the protection of the competition element, so we're rewarding contracts that will continue to patient choice element and offering that patient choice. And just so preempting the next question, which might be the value of some of the contracts we have, where patient flow will typically dictate as well where we need to have a contract, and where an organisation is receiving more than about £500,000 or £500,000 worth of patient flow from our MSE footprint, we would be expected to put contracting in place, so we have some safeguards. We do have some lower value arrangements, but that's some of the other acronyms that might be in the paper.
Thank you. I ask because Neha is supervising a jargon-free environment there. And of course, these contracts, I mean, Monday's documentation from the government says we will be thinking about some of these things over this coming year as well, won't we?
Yeah. So what we're asking is for a 3-year arrangement with those contracts that will help us stabilise the commissioning arrangements we have in this area and allow us to enter into those conversations that will put us on a better longer-term footing.
Okay, but it won't burn any boats as far as what we saw at the moment as just government indications of plans on Monday, because it talked a lot about ISPs, for example, independent sector providers. No, it's not fettering our discretion, I think, is what I'm asking.
Absolutely not.
Okay, any questions or comments about all of that? You look nonplussed. So what are we asked to do? Just to be precise, agree to award a 3-year contract to Mid and South Essex Foundation Trust for General Acute Services from the 1st of April under process A. Agree 1-year contracts to the NHS acute providers specified for general and acute services under process A. Approve the proposal to undertake a self-declaration accreditation process for the existing contracted ISPs with a view to awarding a 3-year contract under process B, and note that the contract values will be in line with what we're supposed to do when we hear that, and that information is arriving later this year than it even normally does, yeah? And do we agree with all of those? Yes? Thank you very much indeed. Very good, and thank you, Jen. We come now to the Chief Executive's report. Tom.
Thank you, Mike. So I think my report's fairly self-explanatory. I think just to draw the board's attention to a couple of items. So firstly, within my report, I've provided the 3-monthly or the halfway mark report through from the Community Services Working Group. There's some really great work going on and some great engagement through that group at the moment. We're still working our next meetings on Monday, focusing on a range of issues, but I think we're going to get some good recommendations to help inform our ultimate decision making around the community services consultation. Secondly, just to reflect, obviously we've gone through a very difficult winter within the NHS. We haven't been alone in Mid and South Essex, and indeed I think comparatively to other systems we've done relatively well against a range of metrics, both as indicated within this report, but equally Matthew and the team have done a huge amount of work to minimise handover delays for ambulances. Our CT response times have held up better than other parts of the east of England, but has indicated much more to be done. Sam will be doing some lessons learned exercises with colleagues across the system, so we can learn from what went well and also what went less well over the course of this winter, so we can use that to inform our plans for next year. And Sam tells me that we're going to start planning for winter in August this year, so that will be fun during a heat wave.
And Tom, is it just worth pausing there? I mean, Matthew, we did seem to be in a better position than others. Do you want to just say a word or two about how that was achieved?
At great cost.
Or two. Thank you for that challenge, Chair. So I think, as colleagues will know, the NHS right across England and the other countries will have that combination of flu, norovirus, RSV infections, respiratory infections, which all came together. So the peaks in demand leading up to Christmas in the first week, 2 weeks after Christmas, and recognise it's only the 16th of January now, so we've got another 2 months of the winter to go, was a particularly pressurised time. So I think the teams across the whole of the system have really worked well together. I think this year, with the establishment of the discharge cell, if I'm sure I won't preempt Sam's lessons learned exercise, but the coordination of services to enable timely and safe discharge from acute beds, and the work that the Community Collaborative have done to reduce the length of stay in community bed base, I think were significant improvements to help the system to remain as resilient as it could be under the challenging circumstances. So, so I would point. I mean, it's a whole range of things that have been happening, but I think the system response has been particularly helpful. And then within the hospitals, our focus on improving the number of patients that are seen in a same-day emergency care setting. So those people that can walk, that are often self-presenting, that could be seen by a physician and then potentially asked to come back the following day. I think that's also going to be a key piece for us for the rest of the winter. So, so I think I would point to those three things, but I think there's been a lot of other things that the teams have been focused on, as you'd expect, Chair.
Thank you, Tom. And then George.
Thanks, Mike.
Is it, we've just carrying on that theme?
It was just basically to ask Matthew whether he thinks demand has peaked. As at January the 16th or...
We'll now hear the brave answer to the question.
Thanks for that. So I think what's been helpful is that the predictions that we've had through from Public Health and NHS England that were predicting when the peak and the reduction in demand in children's presentations were broadly accurate. And whilst my A&E team at Broomfield would not want me to say this in public, today I was in the department, it felt less pressurised than it did this time last week. And again, the public health messaging that we received around peaks in flu and the combination of the respiratory viruses was supposed to start to tail off this week. So I think if we can continue to rely on some of the advanced data analysis that we receive, that will help us in our understanding. But I would remind ourselves, just looking at my screen here, it is the 16th of January. We've got a long way to go.
Thanks, Matthew. Tom?
Yeah, and I think one of the things we're going to try and really push over the course of the remainder of the winter is obviously building on the good work we've done around discharge in terms of how can we really look at coordinating, optimising emission avoidance activities as well. And so we've got the co-location, as I indicate within the paper, going on at the moment around the Unscheduled Care Coordination Centre at Phoenix. And so we've kind of got the end-to-end kind of pathway together. So I think that will generate lots of learning for us as well. Also wanted to just kind of highlight in terms of some of the great work that's going on around starting to utilise and deploy Section 106 money to improve general practice capacity and estate. We've got a long way to go, we know, but actually we're starting to see a pickup in terms of the utilisation of 106 money. So I'm going to keep the board informed on that, because I know this is a key area of concern for local communities. And indeed, if we are serious around left shift and integration, we're going to need to create the space for patients to be seen and for staff to work in. So I think some good early first steps on that, although a long way to go. Finally, it's not reflected within my report because it was written before we received it, but obviously the one component around planning we have received is the elective reform plan, which sets out some quite stretching ambitions for the NHS in terms of the recovery of elective waiting times. So we've got a lot of work we need to do over the course of the next month or so to do some of that really detailed modelling and planning in terms of how do we organise ourselves and how we go about effectively delivering on that, both in terms of the activity requirements, but also for colleagues who have seen the plan. Obviously, there's a lot of transformation of patient pathways kind of implied within that work, and so that needs to be reflected in our operating plan for next year. And indeed, no doubt we will use stewardship to assist us with some of the reform and change in some of moving some pathways traditionally delivered in hospital settings out into community settings. So yes, so whilst we do wait for the full planning guidance to come through, we've got quite a lot we can get started with now. Thanks, Mike.
Thanks, Tom. Questions and comments, Mark?
Thomas, one, using the 106 money to create these premises, is there any issue regarding having the number of GPs to actually operate these premises? So you can build it, but then if you don't have necessarily the providers being able to provide it, or is that not so much of an issue?
Well, I'm sure Alliance directors might want to come in and comment. Dan?
I mean, the ones listed in mid-Essex schemes, it's a bit chicken and egg in some respects. So many GPs will say they've had to turn down the opportunity of recruiting additional staff, be that general practitioners or the additional roles, of which there are a whole multitude, because of a lack of space. Obviously, then when you put the space in, it encourages recruitment. So in many cases, I think a lot of practices have started to say, I guess to coin a phrase, they're bursting at the seams, and they would really dearly love to be able to recruit more staff, but the lack of space is now becoming the rate limiting step. So obviously some of these practices, case in point, are quite rural, and so it could present a challenge to recruit, but actually having the space to be able to house people is massive. And so my hope, in answer to that question, is the more we can offer that, the more attractive primary care will be as a place to work. But Anna may want to come in.
Thanks. So I've got a queue, which is actually Anna, Alex, and then Pam.
Yeah, just really to support what Dan said there. We have got workforce, particularly ours workforce, but also GPs who could be accommodated if we had the additional estate. So I think it's really important to have the room availability, and then we will be able to draw more people into the workforce.
Thanks. Alex?
And just to add that the Section 106 is utilised also for refurbishments, additions. So we're trying to be as creative as we can and use the funding flexibly, also working around utilisation of void spaces and turning any possible office space into clinical space where appropriate.
It's very minor, but the 106 usually can't, well, I don't think it's ever funded a whole building. So we're not talking about whole buildings, we're talking about, as Alex has said, additions, change of utilisation. So what you don't see here is, we're going out for new practices because that goes through a different process.
Thank you. Other questions or comments on the generality of Tom's report? Jeffrey.
Thank you, Tom, for the update. Good to see you were down at Southend for the voluntary sector AGM. So thank you. My question is linked to that, which is around the inclusiveness of the medium-term planning process. To what extent, and you've said there's extensive engagement going on with stakeholders. So my question is around some of the existing partners, like the voluntary sector, for example. To what extent are we engaging with them now or, soon?
So there's been some engagement with the voluntary sector, but I think there's the opportunity to do much more as part, and both in terms of, so I think where we get to with the medium-term plan is kind of a setting out of priorities that we all need to agree, and indeed our partners will need to agree if we're to make it successful. I think then it's working through in terms of the detailed delivery plans to enable the change. Through that, we both need to make sure the voluntary sector is engaged, but equally also need to make sure that in those plans we're addressing inequality where it exists. Because, and actually it draws a bit on what Pete was saying earlier, we know that a significant proportion of excess costs is due to those inequalities, because people aren't able to access preventative services to help keep them well for longer, and therefore are ending up in crisis situations, which cost the NHS a lot more, but actually just as, and if not more, more importantly, actually providing really poor experience with that person and their family. So it's got to be at the very core, I think, of the way that we think about the delivery of the plan. The challenge for us will be how do we rebalance the way that we work within the system within a period of high resource constraint, and that's going to be tricky, but something that we're going to have to kind of see through across our system.
If you look at Appendix A, labelled priorities for December 24 to April 25, there's a lot of things there. And I guess every single one of us around the table has one at least that they'd like to add. I mean, it's a difficult agenda, Tom, isn't it? To know where, I mean, everything needs to be looked after, and we have responsibilities so to do. But the question is how to take the fences one by one, isn't it? Mixing my metaphors. It's a long list.
It is, and you should have seen the initial list in terms of things that we were working on within the ICB. So the purpose of these priorities was really just within the ICB itself, to be really clear about what it is that we wanted to do over the course of the remainder of the financial year. And against a lot of these, we are now metrics or deliverables associated with them, and so we can be really delivery focused as an organisation. These will morph into the medium-term plan is the intention. So this was just a kind of a stopgap solution. We have made some changes also that we're implementing around the way that the executive committee works, and so we're moving now to having a much more structured, thematic conversation, and so we make sure that we're covering both these priorities, but equally also this Tuesday we had your focus on quality and safety of services. So we can make sure that the work of the executive committee is adequately servicing and providing the assurance that this board needs moving forwards, and that will involve much greater use of data to support that.
Thank you. Neha?
Yeah, just on your last point, which you ended with, Tom, and going back to Matt's point earlier. So in an ideal world, we'd like to do these and much more. This is already quite a long list, as you just said. How are we using data? How will we, in terms of identifying within this, those where the benefits realization in the broader sense, not just financial, clinical and financial, is almost, sets some of these apart a little bit to guide us as to what is not just the art of the possible, because all of this should be possible for us if we want to serve our population, but what realistically are the chances from this list?
Yeah, so I think from this list, we have got things that we think that we can do, within the time period we've got available, and teams have committed to delivering on through the engagement process we went through. More broadly, in terms of the longer term, sort of the medium term plan commitments, and Joe might want to talk a bit more about it, is we are doing that piece of work in terms of sort of kind of deliverability versus benefit. And when we say benefit, we're not just talking about money, we're also talking about where we know that, we've got particular issues or concerns in terms of outcomes or access or whatever else it may be for local communities. And so we can be quite prioritised around that. And also think about how do we sequence things in terms of those things that will give us the greatest return or the greatest benefit first, which will then potentially enable us to go and do the other things that we want to do. But Joe, I don't know if you want to talk a little bit more about that.
Yeah, I think so. The work of the medium-term plan is to create a system that is clinically, operationally, and financially sustainable. So thinking about patient outcomes, access to services, etc. And as Tom said, we've got to be able to phase that in such a way that's going to enable kind of us to drive out excess costs and to be able to invest differently in the way we provide services, but also to scale things. So some of the work we've been talking with the alliances, doing fantastic things. We need to be able to scale those to see the impact so that we can left shift with confidence, so that we can, analog to digital, treatment to prevention. So the medium-term plan is around those three big shifts. I think what we need to be able to do is to quantify how quickly, at what pace and what scale we can move to deliver these priorities and change the way that we deliver care in the system.
Thanks. And then the appendix also B talks about the community consultation working group, and what I noted from that is that we're learning lessons about how, when we need to address difficult issues, we're finding the better ways to go about engaging with people to do that. And again, Tom, I think that's you and the team's inspiration to sort of come onto that, and that's much appreciated. So that's just for noting. So any other questions or comments on Tom's report? So now I need to move us on. An opportunity, Tom, to thank you for everything you do, and we're looking forward to working with you in the new year. And everyone appreciates both the matter of your engagement, but also the manner in which you engage with us. So thank you on both of those fronts on behalf of us all. We now move on to quality report, and Giles, that's you.
Thank you, Chair. And as always, I will take the report as read, but highlight some key points within the quality report for this reporting cycle. and to note two escalations from the Quality Committee, the first in relation to the sodium valproate patient safety alert, which many colleagues will be aware is the negative impact on women and pregnant people who have historically undertaken sodium valproate and the impact on their pregnancies and outcome of pregnancy. There still remain some actions within the alert that have not yet been fully evidenced. And my thanks to Nihar as chair of the Quality Committee that has certainly commissioned a deep dive report in February of this year to gain further assurance. In relation to meds management and the overuse of opioids, whilst as a system it is positive to note that we are at the lower end of the spectrum in relation to patients taking opioids overall, there does remain an ongoing issue in relation to the use of high-dose opioids and long-term use. And Dan, who attends the Southend Essex and Thurrock Suicide Prevention Group, shared with the Quality Committee some quite distressing data, which is real-time suicide surveillance, which does show a high correlation between suicide and long-term opioid prescriptions. Positively to note, there is work across the system in relation to the minimisation of both the prescription and use of opioids. And my thanks to colleagues both in the acute and in the primary care settings that are working with individuals to minimise the use in the first phase, but also as well to undertake opioid contracts with individuals where there will be agreements for deprescribing and refraining from restarting opioids for those patients who are discharged from hospital, and in particular the community musculoskeletal pathway, which has been commissioned, which is a positive step forward where we do see higher use of high-dose opioids. From a national perspective, and as we move into 25-26, there are a number of national directives which are coming through for us as an integrated care board, not least to note that the national nursing and quality strategies are now being aligned with the 10-year plan. And I would note the focus on the kindness to professionals, which will sit within the nursing strategy, and also as well sexual safety, which maintains an ongoing area of focus for our populations across the country. The insightful board guidance has now been released both for provider boards and for the ICB boards, and this will form part of our board development programme. And alongside that, to inform the board of current regulatory activity, of course, our providers continue to be visited by our regulators, and I have provided the list there. And of course, as will have been noted nationally, there are some ongoing delays to reports, but we continue to work with the Care Quality Commission and our providers and seek assurance that there are no immediate patient safety concerns. Further national programmes of work which have been undertaken, and really pleased and a sense of pride actually for ourselves as one of two integrated care boards as pilot sites. We'll be working with the National Quality Board to be implementing the principles for assessing and managing risks across integrated care systems, a very snappy title. However, we will be identifying a couple of system level risks, which I think will change the conversation and allow us as a system to understand our risk appetite and our risk profile. Looking to Sam, I think one of those will be on flow. And alongside that, there is now a new national tool which will help us understand who holds responsibility for what in the system, which is the RASCI tool. It is something which is utilised in other industries, and it's really positive to note that this will form part of our quality development in the year to come. Those are really the key highlights, Chair, and I'm happy to take any questions. Thank you.
Thank you. Don't you love terms like RASCI? It's instantly memorable.
I want to say rascal, but I won't.
I was trying to turn it into that, actually, which would be the rascal in me. But so, Neha, is there anything you would like to add first of all?
Just to thank you, Jazz. That was really helpful and very succinct in terms of highlighting the key areas of strength as well. The opioid work actually has been done quite long. You know, there's not the progress that you'd shown or spoke about was actually quite a lot of work done in the community. And I remember we had a deep dive session and a lived experience from our pharmacy colleagues in medicine optimization, and Paula Wilkinson coming for that as well. And I think that just highlighted that kind of, on the ground in the system, working with people, working with frontline professionals from all areas, and there was a lot that went into that. I think it is also an example where we might be doing very good in one level where the opioid is, but it could tip us at the other end in terms of high dosage and so on. And again, we should make use of that system and other colleagues in the system to make sure that we stay, where we intend to. But I think that was, I think it was some time ago now, and might be time at some point to revisit that and see how we're doing in ensuring that in terms of high dosage, we don't go further.
Anna?
So thank you, Nia. When I was chair of Essex CCG, we were served with a prevention of future deaths notice by the coroner about a patient who died from an overdose of prescribed medication, including high-dose opiates. And I would still very much like to see the ICB considering the commissioning of a service to provide de-prescribing support to general practitioners. This is something that GPs have been asking for years, and it is really something that we should look at again with a lot of seriousness, because it's a very difficult area to get right. It's complex. It often requires support for patients with mental health conditions, but it is a really useful and, I think, caring thing to look at, and would be very much supported by GP colleagues and community pharmacy colleagues. So I just want to put that out in public, that I would like us to look again at de-prescribing, formal de-prescribing programs operating in primary care. Thank you.
Matt?
Yeah, thanks, Anna. Couldn't agree more, and particularly with the complexity and the nature of these patients as well, particularly on high dose. Just two things to add, really. A part of it bringing to board today is to very much have it as a high profile, to say that this is really important to us and we want to deal with it. Very much conscious of previous coroner's inquests and potentially coroner's inquests coming up. Secondly, this was raised literally this week at our quality executive, and we will have a paper coming back next month to quality executive, looking at what we've done before, what are the potential options, and particularly linking in with primary care around how we see going for the future as well. So I think probably just to reassure, it's back on the top of our agenda. It's a quality committee, it's executive quality as well. But thanks for the challenge, Anna.
Mark and then Alex.
I mean, also the Pharmacy and Medicines Optimisation Committee is very focused on the monitoring the trends in those areas as well. On the RASCI, or as we used to say in the place I worked, RACI tool. It's I think it's pronunciation of the I. It's actually a very good tool. I mean, it does actually make clear who is responsible for something. So if something goes wrong, where do you go to? But also clear on who you should consult and inform when there are new things going on. So we applied it many years ago across all the risks, so that everything was documented. So if something happened or something came out, you could immediately go to saying clearly who's responsible, who takes things forward, who gets consulted, who gets informed. So would recommend it highly.
You've just volunteered to be a co-leader of one of our board seminars and better inform us about racy stuff there, Mark. Thank you very much indeed for so volunteering. Alex?
I just wanted to add, following from Anna's comments, to ensure that we link with our colleagues in local authorities, public health teams who hold a number of substance misuse contracts. And again, that is the same conversation that is happening on the other side of the table. Make sure that we're involved along with OHID, because that is also high on their agenda. Thank you.
Thank you. Any other questions or comments on the quality report? We've a number of things we're asked to do, a couple of things to note, which we do, and support the implementation of the NHS Insightful Board guidance, which we have no choice but to do and will. And we note the currently well-publicised position in delays in the Care Quality Commission, though nevertheless we have to remember, I think they're the regulator, and so we're humble supplicants would be my view, but others may differ. Support the implementation of the assessment and management of risk in line with the national guidance, and we need to do more work on that, don't we? And then we've just been talking about what in my mind is always now going to be racy, but perhaps not in an official meeting with that one. So thank you very much indeed, Giles and colleagues who put together the quality report. And we now move on to finance and performance.
Thank you, Chair. So the board's in receipt of our month 8 finance report. Month 9 figures are have been finalised this week and are going through organisational governance. But I can give you a little bit of a heads up around that as we move through the report. So I will take the report as read. I think it's worthwhile just remembering as a board that we do have an agreed planned deficit of 96 million. We have been in receipt of deficit cash to support that position, which is why some of the tables therefore show a break-even position. However, it's the 96 million plus or minus what we deliver this year, which will be expected to pay back. So there is not a financial benefit in terms of receiving that 96 million. It just ensures that the cash is flowing around the system, around the NHS more widely, effectively. I would just say we have seen a slight improvement between month 7 and month 8. So we saw £1 million improvement in our run rate. That has held into month 9. That has held and in fact improved into month 9. So some really significant evidence of all of the actions and all of the work that we've been going through recently as a system starting to bear out in the numbers. We know that month 10 is going to be really pivotal for us in terms of all of the pressures that we faced across the whole sector over the winter period. So that's going to be quite telling in terms of where we actually land the end of the year position. I think at the moment, you'll see from the numbers, the ICB had a month 8 variance or a month 8 adverse position to plan of 2 million. We know that our all-age continuing care pressures, both value and volume, are continuing to exert pressure. But at month 9, given the additional resource and focus we've had in this area, we are starting to see improvements in that all-age continuing care run rate. And I am assured that we will be able to bring the ICB back into a balanced position by month 12. I think largely we recognise that delivery against our efficiencies has escaped us, unfortunately, again this year. And whilst the report alludes to us continuing to deliver the 168 million that we set out to do, I think we're clearly going to fall short of that as we move to the end of the financial year. I think we could easily be looking at adding at least 30 million onto the position that we're currently reporting in terms of the 96 million deficit. So not a great position to be in, but I think the fact that we have seen an improving run rate, and actually for our acute sector and MSCFT in particular, we're looking at almost 4 months of improvement, gradual improvement, which is really significant. And I know that there's just been tremendous effort across that sector and a phenomenal amount of hard work to get us to that position, and some hard decisions, which I think will continue to support our exit run rate as we move into 25-26. I will pause there and open to any questions on finance before we move to performance.
Mark.
Thank you. Just interest on the healthcare element, obviously a key driver of the costs here. You mentioned that in period 9, this may be too early to ask this question, but you've seen some improvement. Do we know if that's driven by less eligible demand or better value, or a mix of both?
In all age continuing care?
Yeah.
So I think primarily that's been driven through some of the changes that we've made to ensure that we're getting people to the right place at the right time as they're exiting the hospital. So previously we recognised that we had a significant cost pressure in an area which we call our discharge to assess, which is where our residents are coming out onto care packages, waiting for an assessment to whether there will be local authority or whether there'll be continuing healthcare. There's a lot of work that's gone into that area to look at those pathways and to understand what that looks like. And the backlog that we've had has been driven right down. And I think it's quite interesting with CHC in particular. We saw a kind of blip in the numbers, driven through some really hard work to get the right data in place to really understand what was going on. That blip has then allowed that data analysis and that position that we're now in with the way we understand the pathways, the way we understand the information that's coming through, we are then being able to target those interventions. So I think it's been a very single-minded, continuous, relentless focus on a particular area at a time that's helped us to see the differences. I don't think we're out of the woods yet with all age continuing care, and I think we probably compare if we benchmark across the region, we've definitely got some we could do better. We can continue to do better. We're trying to work now with our regional colleagues and across other systems in our region to understand operationally how are we different, why are we different, what's that look like, what learning can we develop from that? Because I think it's been a national issue for both local authority and health in this space, hasn't it?
Thank you. Other comments around the finance or questions? I mean, I'm aware from the group of East of England ICB chairs that everybody's financial position is somewhat challenged for this financial year, and indeed, even in those ICBs that thought they would be, in everything shipshape and tidy position, are finding it challenging. All age continuing care is one aspect, winter pressures will be another, etc., etc. So let's be clear, this is particularly challenging for us because we know we were correctly identified as, living beyond our means as a system, and we've been working very hard to do something about that together. But even those that started in much better odour, so to speak, with people above us responsible for the funding of the whole of the NHS, they have found that the position has declined. So I'm just pointing out that this is challenging territory. That is not in any way to let ourselves off. We must be responsible in our use of public money, but it would not be anything other than the truth to say it is especially challenging for everybody out there at the moment. So move on to performance.
Yes, so I will take the performance report as read. Obviously, we're reporting on just a small number of constitutional standards at the board here today. There's a lot that sit behind this and other metrics, etc. And we might invite other members of the exec team to comment on any actions that are happening. I think it's fair to say, as we do regularly, unfortunately, that we are not where we want to be with performance, that we are struggling to deliver the commitments that we have made in our operating plan, which therefore means we're struggling to meet our constitutional standards in that space. We do have our constitutional standards around mental health, which we do report are being sustainably delivered. There are obviously a vast amount of other metrics across mental health as well, but these are the two clear constitutional ones. I will pause there because I'm conscious the board might want to take some time to ask questions.
I mean, the key one, sorry, George, do you want to come in first? No. Okay, well, the key one, I mean, is obviously, since we know that our cancer performance is very poor. So the question is, to remind ourselves what work is going on, and are we seeing, any effects? Can anybody update us in where we are with this? Because we really do have to get kind of on top of it. I don't know who would want to come in and sort of talk a bit about where we are with all of that. Matthew, do you want to say something about the work's going on? Tom, anybody around the table who knows? Because we really have to do something about this, don't we?
Yeah,
together.
Totally agree, Chair. And obviously, one of the actions earlier in the meeting on the action law was specifically to raise a concern with us and our board in relation to cancer performance, which we're following up with ICB colleagues. Next week, I think we have some time to really work through an understanding of the drivers of the challenge position, but also the route out of it. I think what I'm sure will be a feature is referring back to some of the changes that we've made within the organisation to drive down cost, particularly driving down costs related to bank and agency spend, has exposed some lack of resilience, long-standing lack of resilience in some of our specialties. And given that cancer care is delivered by many specialties, particularly many surgical specialties, it will lead us to, I think, Chair, a medium-term plan that sets out how we rebuild resilience in some of those specialties so they're not dependent on a temporary workforce in order to deliver the performance that our patients deserve within Mid and South Essex. The board's very committed and well cited on the work that's underway. Tom and I have already had discussions about a system response to the cancer performance, because clearly we need to make sure that the right patients are referred in the right way. And we also, as I said, need to make sure that we are working with our clinical teams in order to rebuild that resilience, which I think has been exposed as we've driven financial rigor into the organisation that didn't exist before.
People may have understood you better than I did there, Matthew, because of my lack of experience in the NHS. But I mean, can you explain how the resilience issue, this is, we've got waiting lists longer than they should be, both for have I got cancer or have I not? And then we've got waiting lists longer for treatment if you have than they should be. Can you just
explain? Of course, Chair.
Sorry,
So,
and I'm probably the only one that needs.
No, apologies for perhaps not being as specific as might have been helpful. If you look at the faster diagnostic standards, so how quickly we diagnose, so how quickly patients are able to get a scope or a scan to help, that is starting to improve in the way that we hoped it would. The challenge for the specialties that are dependent on temporary staff is where essentially the capacity that is needed to see patients within the required waiting time has been dependent on, in a number of our specialties, on essentially a temporary workforce. And that temporary workforce usually came from our own staff doing more hours. Where we have taken decisions to provide the rates of pay that are consistent and competitive, some of our specialties have decided that they're not going to provide that temporary additional capacity. That has started to drive into some of our waiting times of late. That's one example. It's not the only example of where we have lacked resilience in our workforce.
Okay, thanks. And I've got it now. And I'm familiar as well with the issue that's around, in a sense, are people being sent for referrals and then that then get worried and really had no need to be sent. And I can't remember what it is, if anything, that we're doing about that, because I did see some statistics some time ago, and I haven't seen any statistics more recently. And I know I'm cueing you, Neha, but has anyone looked at that?
Yeah, so we've now got an agreed set of priority areas that we're working on with the hospital in terms of how we can support those pathways and indeed maybe create new pathways for various cohorts of patients in particularly some of the higher volume specialties. So that's now been agreed. We are hopeful that we will get some more resource through the Cancer Alliance. So that's the East of England regional support arrangements, which I think will help us accelerate some of that work. So we can be, so we've got much faster, both much faster pathways, but equally also we've got alternative pathways for patients who perhaps are proceeding through a 2-week wait or suspected cancer route, who may not need it but need something else. So we've got that agreed now. I think we've got a resource route lining up for that, and so we can then crack on and working with the hospital and GP Collaborative and others to put in place those pathways.
Thank you. Sorry, Neha. Thanks for your patience.
No, thank you.
And then I must go back to George.
Have I jumped the queue?
So you have.
Oh, please. I can blame the chair here, so go ahead.
No. I just picking up. The government announced that community diagnostic centres will be open 7 days a week, 12 hours. I think from June is the timing. I'm not sure whether that's an intention or it's mandated. So I guess my question, concern is, based on what Matthew said about workforce, is getting prepared for that. And also I would caution about, you'll do more patients in 12 hours, 7 days a week, unless you know what your current utilisation levels are running at. Recently, not within this system, I had a scan on a Saturday and they were on at 20%. So we need to really understand current performance levels. How do we take that up to, 80, 85% before we start expanding the working day, putting in more cost without the utilisation? So it's a bit of advice, please. Thank you.
Do you want to comment?
So yes, I think we'd all agree with that. I think that is the commitment in the elective reform plan. Obviously, what we need to work, we haven't got the system allocation yet, and so what we're going to need to do is work through that commitment alongside the system allocation. But I suspect it will need to feature in our operating plan that we submit as a system back through to NHS England.
And, and all respect to governments and all the rest of it, but it's taking a little longer for these new community diagnostic centres to get built than at the moment they think they're going to, sadly, because it just takes the time it takes at the moment. Neha.
Thank you. And I think it ties in a little bit with what George had already said, but I'm going to go with the earlier speakers. There's no stupid question. So Matthew, you did say we're relying on certain specialities on temporary workforce, but given that we know the pressures are so high, the lists are so long, any reason why we don't then therefore have already started plans for substantive workforce, because we will need it and we can't rely on the temporary workforce for much longer? So why is this still temporary?
Yeah, so absolutely. And we've, as part of our financial turnaround program within the organisation, we have commissioned an organisation to help to benchmark our medical rotas against similar sized organisations with similar levels of activity. That report will land in my inbox tomorrow, which will, I anticipate, show where we are under-resourced, and it will lead to a significant recruitment drive in those areas.
Thank you. Other questions or comments on the performance report? If not, then we're here to note it, and we have. Thank you very much, Jen and team, and for all your hard work in and all those connected with getting us into a better position with the finances. It's much appreciated wherever they are within the system. We move now on to the Primary Care and Alliance report, and I've got a team of contributors here. Pam, you're first on the list.
Yeah, thank you, Mr. Chairman. And I'll take the paper as read. We've talked about some of the primary care achievements throughout the meeting, so I'm not going to go over them again. But just to say that the team continues to support general practice in its purest sense, as well as the primary care networks. And we continue to support some redesign of the primary care networks. And that goes on in the background. So we'll report as those are completed. I did just want to bring to life, we've decided with this report as it goes through refurbishment to include a patient story. And the story that we've brought into this paper is around our transfer of care hubs. Again, we'll take it as read, but I think it's a very good demonstration of the transformation that's happening at place level, which connects our hospitals, the discharge and flow processes right back out into primary care, which in my years of doing this, we haven't had a consistent way of doing it. And that is becoming more consistent across the path. It's a very good read. It shows about that shift from prevention, treatment, using wider community assets around social prescribing, and the way that the practices have that continuity of care and link into social care for prevention measures, and again working with our community teams. So I'll hand over to, which way am I going, left or right after that?
Shall we go left? Thanks, Chair, if that's all right. So just to, again, taking paper as read, but highlight a couple of areas around alliances. As noted in Tom's report, there's a number of priorities that alliances have now wrapped around in terms of the delivery. That is supporting us maturing our integrated neighbourhood teams, and we are looking to do that through being data-driven and clinically supported by our stewardship colleagues. As mentioned, we continue to work on utilisation on 106 and void spaces, and recently started very quite exciting engagement of our NEDs around visits to alliances. So we have had visits with Joe, who's now in here with us today, around CDCs, and George joined us in integrated medical wellbeing centres. So it's my plea to others to come and see us of alliances being in action. Thank you. I'll hand over to Dan.
Yeah, Mike's slightly sad news. And in Mid-Essex, Alliance Chair, a lady called Sarah Green, who's also the Chief Executive of Farley Hospice, has had to resign as Alliance Chair. She's also had to resign from her post as Chief Exec of Farley. Sadly, she's having to deal with quite a complex family illness, and so she's taken the decision to step back from work. So I just wanted to formally note my thanks to her, both for her contributions to our Alliance and leading that as Chair, but also her contribution to Farley. For a number of board members, she will still be present when Farley have agreed to host us for our NHS England quarterly review meeting next, so we will be able to thank Sarah in person, but I'd just like to note that here, please, if that's okay.
Thank you. Questions or comments on the primary care report? I just wanted to ask, it says here we had a sort of general discussion about the Better Care Fund. What are the next steps, if any, going on from this? Because I thought we were severally and together going to be sort of questioning whether or not, and we should do because it's a lot of money, are we making the best use of this, given now that we are working together better than ever? Is the discussion going to continue, or in a sense, have we now felt that that's as far as that conversation could go? And I can't surmise from the report here which of those it is.
I was going to say, but it's probably not fair with Peter not here from Essex, but from an Essex perspective.
He has the flu, by the way.
Yeah.
We said no thank you.
Peter is unwell and couldn't find a replacement last minute. But from an Essex point of view, there's a large meeting tomorrow, Mike, of all executives from within the Essex system and the ICBs adjacent to ourselves to further that exact discussion.
Great, that's good to hear. Thank you,
Same
Jeff.
applies to Thurrock, just to say that we're in constant discussions.
Excellent. All right, thank you. Jeffrey, and then Mark, were you looking to come in or not?
Yeah. I was going to remind you, Marcos wants to speak as well. Yes. Thank you. I'm not sure if it's applicable here, but something called LCS, Chair, which I think stands for Locally Commissioned Services. How is that going? Because just out of curiosity, I didn't see that here. Would that be something that applies to your team to be able to update roughly how that's going, and what's the future of that sort of thing? Thank you.
You've nonplussed them, Jeffrey.
I don't think I have a direct answer to that one, to be honest.
Okay, so
yeah.
We'll have to respond to you outside the meeting.
Yeah, maybe Anna, as a GP, maybe is aware of this, but I'll take it outside of the meeting.
Is it local enhanced services?
Local commissioned, LCS, long-term, yeah.
No, I'm not sure.
Yeah.
Is it the locally enhanced services?
Yeah, deal with long-term conditions and things like that, yeah.
Yeah, okay, sorry. I didn't know
Your things are pressed. Hey.
I'd switched it off, sorry. We have a programme of local enhanced services for primary care, and the DESs are nationally defined ones. So we have less ability to flex those, of course, but obviously work with the implementation of them. The LESs are under review at the moment. We're working through a programme of them. There are some contentious areas. They supplement obviously specific pathways and areas of concern. And there is a variety of LESs out there at the moment because of the history of 5 CCGs, and we're working to see exactly how we standardise those across the patch. There is inherent risk in that because and it pushes back up to our provider system, as well as our community colleagues, in the way that we all work together, that we do have different systems and processes for the 3 hospitals. So it will require a whole system solution in some cases, and some more standardised care. But that's quite a typical presentation for a system of our scale and complexity, really. We have some very focused support around medicines management and optimization because of the changing platform of drugs coming on and off license, etc. But we're fairly typical in that case, but it is something where it is discretionary spend, and obviously with our financial position, we're looking at how we can get the best value out of that and support primary care at the same time.
Okay, so this is responsible consideration where we have discretion about, because obviously if we take money away for discretion for things that we really have to do, the question needs to be asked, and that is being asked. So hopefully at a future meeting we will get a report about what we're going to do and why, and also what the sort of range of these services is, because I'm sitting here and I can't begin to imagine what one might be.
So it's something like taking blood in general practice. That would be
okay.
a local enhanced service, because phlebotomy doesn't exist as part of the GMS contract. So if a GP practice signs up to a local enhanced service to provide a phlebotomy service, and they paid additional funding for doing that.
Right.
That's
Okay, and now I understand how that then might impact on our hospital. Yeah, thank you. Thanks. It's an education, Jeffrey. Thank you very much.
Apologies, I didn't understand the question to start with.
You and me both. So that's all right.
Terminology.
I thought there was another acronym I didn't know, and indeed there was, but not the original
And maybe
one.
I didn't ask it very well as well. Yes.
Mark, were you looking to come in? Yes.
Yeah, it was just to jump back to the BCF element and one to add on South East Essex are doing the same thing in terms of reviewing that in totality with how we're spending the IBCF as well through the local authorities. And so it's also worth mentioning we were made aware this week, so at the end of the planning cycle of the current BCF arrangements, we're awaiting the new guidance. We have been advised it will be a 1-year plan only with a change in metrics. So I've got some of the metrics, which if you haven't got, we can have a chat in the break. That might be a good opportunity to really look at that, because there's going to be some different expectations. No national performance indicators are to be locally derived only, and welcome news, they are going to cut back on most of the bureaucracy around recording and reporting, so it's going to be very light touch going forward. So I think that in line with what we're doing now, the view being that as of the following year there'll be a 2 or 3 year plan once the new government decided how they want to kind of do this work and pull it in. So good opportunity for us to review. There'll be more expectations I think going forward.
Yeah, excellent, thank you. Okay, so I think I can move on from our primary care and alliance report. I mean, things continue to happen in that space, which is tremendous. Thank you very much to everybody involved in the hard work in moving things along. Partners and whoever they would be, because it's coming together that makes it all happen, isn't it, really? Thank you. So then we've got some papers of just general governance. We've got the board assurance framework there. So Tom?
I think it's here for any questions or comments of board members.
Thank you. I mean, I think the trouble is there's so much in this because it's done for a particular purpose. So I think I have a sideline in music, and for me this is the Schoenberg of organisations, in that most people can't listen to Schoenberg because there's the complexity and density which is too much. And I think in a sense we could do with a Taylor Swift version of this.
Oh, contentious.
where the communication was somewhat more direct.
So I do think it's kind of to take the Taylor's version of the board assurance framework. But so I think reflecting on, say, the conversation we had earlier today around the seminar session, I do think there is an opportunity for us to think about how do we refocus the board assurance framework around our strategic objectives. And I think we're approaching the point where we'll be able to do that, and therefore then start to very clearly link through the work plans that we've got in place within the system to address that, and the metrics. And the other question I think we should increasingly start to ask ourselves as a board is, to what extent are the agendas that we are considering addressing these risks and providing assurance around these risks. And so I think that's an area of development for us as we move forwards, and to help with kind of making it accessible and understandable and being the assurance document that it needs to be.
Yeah, and my silly meta was really just drawing attention to something where we can all get our heads round what it is that we need to focus on. And that can't be everything all the time. It would be better to look at one or two things, really carefully and thoroughly, and let's see if we can do that. So it was in the spirit of moving us on with it, really. I get risk management for sure. It's very valuable. There's a set of new revised policies which you have there. They have been through the relevant bodies. Anyone got any comments, or are we happy to approve? You are. Thank you very much. And we've got the approved committee minutes. And I don't know if any of the committee chairs who are here want to say anything about those. I expect people to do that if they think there was something that they needed to draw our attention to if we haven't otherwise done. If not, I've not been notified of any other business, so I can therefore thank you very much. That brings us to the end of part 1 of our meeting. There's now a short pause while we say thank you to members of the public in person and online. So a 5-minute facilities break, and then we go on to part 2 of our agenda, which is matters of commercial confidence. Thank you very much.
He's accusing me.
I never thought Taylor Swift